Okay, Dr. Calamia, you can start now.
I don't think he heard you.
Dr.
My
Calamia?
apologies. I'm so sorry. I was on mute. I did, however, intend to welcome and thank you all for joining us today for the meeting of the New York City Health and Hospitals Medical and Professional Affairs Committee. So today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the MNPA committee meeting that was held on November 1st. So if I
So
can get a
moved.
motion. A second. Let me go through the roll for approval. Dr. Pagan,
Yes.
Dr. Katz,
Yes.
Sally Hernandez Pinheiro,
Yes.
Barbara Lowe, Barbara. You may be on mute as I was before.
Oh, the
And is
button disappeared. Yes, please.
there we are. And Dr. Martone, I didn't see you there, but I can't quite make out. Is Dr. Martone there?
She's not in yet.
Okay, no problem. All right, so motion does pass. So thank you all. Minutes are now adopted, and our next item is actually an action item, which will be presented by Dr. Patsy Yang, and this is referring to our EAC network resolution. So Dr. Yang.
Good morning. Good morning. Thank you. I actually wanted to introduce Ellie Epstein, who is responsible for the program, among many other things, all of our reentry and transition services, and she's actually going to present. So thank you.
Thanks. Good morning, everyone. Thank you so much for having me. My name is Ellie Epstein. I'm a senior director with Correctional Health Services, and this morning I'm requesting permission to enter into a contract with EAC Network for Community Reentry Assistance Network services. The Cran, which are better known as Cran. Cran services provide reentry services for individuals who've been incarcerated in the New York City jail system, with a particular emphasis on those receiving mental health treatment while in custody. Cran provides case management services for up to 6 months post-release and a wide array of sort of one-stop shop style services, such as assistance applying for benefits and housing post-release. CHS is actually legally required to provide these services to patients receiving mental health treatment in custody as a result of the Brad H. class action lawsuit, which was settled in 2000. These services were originally provided for under a couple of separate contracts known as Link and Span, but were reorganized and consolidated into what is now the Cran contract in 2017. Next slide, please. So EAC Network has been the Cran vendor since 2017, and their contract is set to expire at the end of June. Engagement in Cran is completely voluntary, and service plans are unique to each participant. Although Cran strives to connect everyone to care in the community, clients are not required to accept specific services or attend appointments. Approximately 1,800 clients a year are served by this contract. 96% of those who connect with Cran in the community receive at least one meaningful service as defined by CHS. So that includes things like assisting clients with getting their prescription medications or attending appointments, transportation, and completing benefit applications. In the last 3 years, they've made over 3,000 unique referrals to engage clients in treatment, education and vocational programs, and secure housing. And more than half of seriously mentally ill clients who work with Cran post-release are successfully connected to treatment. As I'm sure you're aware, this can be a difficult patient population to engage, and CHS is happy with the quality of service provided by EAC. In addition to providing clients with the services they request, EAC has also successfully met all the performance metrics outlined under the Brad H. settlement agreement, which includes making thousands of calls to outreach clients and confirming connections to care. Finally, the historical budget for the program is listed here, and the award will be capped at $5 million a year. Although we're expanding the patient population able to receive services and increasing the scope, which I'm going to discuss in a moment, we actually aren't increasing the budget as the total jail population has significantly decreased since the last contract. Next slide. So although CHS is satisfied with EAC's performance, there have been some challenges over the course of the contract, and we're taking this opportunity to make some changes. One difficulty has been with data collection and reporting. This was a new program, and it took a significant amount of time for the vendor to get an electronic case management system up and running. The good news, though, is that with this next contract, everything is already set up, so we should not encounter those difficulties. As I mentioned, CHS is actually legally required to provide these services to individuals receiving mental health treatment while in jail. Therefore, perhaps it's unsurprising, but the original iterations of this contract limited services to that patient population. This new contract will expand eligibility and access, so post-release services will now be available to anybody who has been incarcerated in the New York City jail system. We've also expanded the eligibility criteria for case management services, which were historically only available to patients with serious mental illness. Moving forward, patients with neurocognitive or neurodevelopmental disorders, less serious mental illness with co-occurring substance use disorders, or other significant healthcare needs will also be able to benefit from this higher level of support. Finally, we're expanding capacity and expectations around outreach and engagement. The new contract will provide for Friday evening and weekend support and emphasizes provision of cell phones and community escorts. Next slide. So I apologize, I realize it's a text-dense slide. This is a large contract, and as such, there are significant expectations of the vendor. The contract requires the vendor to provide case management services and a range of reentry services, including helping patients get connected to their appointments and prescription medications, helping people secure identification, completing benefit applications, and providing housing assistance. They must offer walk-in services and, as required by the Brad H. Settlement Agreement, maintain client-facing office space in all 5 boroughs within a half mile of the courthouses. In addition to providing on-demand services during normal business hours, they must also provide crisis intervention services and have support available for clients on evenings and weekends. CHS is the primary referral agency for Cran services, and so we work very closely with the vendor to ensure that patients get the support they need pre and post-release. In practice, we're in daily communication with Cran staff, which does generally provide good insight into their practice. However, on a more formal level, vendor is required to provide line-level reports and a random selection of charts for review on a monthly basis. They also participate in bi-weekly case conferences with CHS social work and leadership. Finally, the contract includes the performance measures outlined on the slide, such as the requirement to admit at least 75% of people referred for case management, and to provide clients with at least one requested service. Failure to meet performance targets can result in financial penalties. Next slide. So this is just a brief summary of our procurement process. The solicitation was public and sent directly to 5 vendors who are well known for providing social support to individuals impacted by the criminal legal system. Although there was some initial interest, we actually only received 1 proposal, which is from our current vendor, EAC Network. That said, we did follow normal procedure, and the committee scored that proposal, which was awarded an 8.9 out of 10. Next slide. So as EAC is the incumbent, we're very familiar with and satisfied with the quality of services they're able to deliver. They have significant experience providing services to this patient population, navigating the criminal legal system, and meeting the service and reporting requirements of the Brad H. Settlement Agreement. It's also worth noting that our confidence in EAC is echoed by many other providers in this space. They actually submitted 18 letters of support with their proposal, including from some of the vendors we had actually invited to apply. Next slide. So as you may be aware, nonprofits are exempt from the MWBE waiver process. However, I do just want to note that EAC has an incredibly diverse workforce and that the contract requires they provide services in the language of client's choice and that they employ peers as part of the care team. Next slide. So to summarize, Correctional Health Services is requesting permission to enter into a contract with EAC Network for Cran services. This would be a 3-year term with an option for 2 one-year renewals. The total cost is not to exceed $25 million, which is fully funded through the CHS budget. And as they are the incumbent, we anticipate minimal time for transition so that the new contract would be starting in July of 2022. And with that, I want to thank everyone for your time and consideration and invite any questions you might have.
And I think I neglected to formally read into the record the authorization request. I'm going to do that now, if that's okay, which is that we are requesting from the committee and the board authorization for the New York City Health and Hospitals Corporation, the system, to execute a 3-year contract with EAC Network, EAC, for services to operate the Community Reentry Assistance Network, or CRAN, the program which assists people who are detained by the New York City Department of Correction as they leave detention and reenter the community, with the system holding 2 one-year options to renew for an amount not to exceed $25 million over the entire potential 5-year term. I think that's our request. And as you could hear from Ms. Epstein's presentation, this is a tough service. It's a challenge, but it's a critical one in terms of our helping our patients to leave jail and reenter the community successfully and not come back. And really, under Ms. Epstein's leadership and creativity, we've expanded the population, the eligibility for services, as well as the service scope itself. Thanks.
Thank you. I have one quick question, then I want to poll everyone else, but relating to the budget. So as I look at it, it seems that as you mentioned, due to the population falling, the numbers served actually were falling. Looks like 2019, it was 2,200, and 2020, our COVID year was 1,100. But if we look at the actual budget spent, the numbers didn't really drop very significantly. And I now understand we're going to be expanding those services to broaden beyond the seriously mental ill. So do we think this budget is going to be fitting in? Does the budget change with the number of people being served, so that if we do have a lot more served, that we do have that ceiling raised? Or how are we handling that?
Sure, absolutely. So I think it's a good question and answer. The budget expenses are basically entirely staff and rent. So again, because of the Brad H agreement, they are required to have office location and frankly prime spots in all 5 boroughs. So that's a significant expense of the contract that doesn't change depending on the number of clients served. And then the staffing doesn't fluctuate from year to year because we anticipate and we want to account for the possibility that clients will come in and ask for services, and we don't want to be in a position to turn them away. So again, the staffing here, although the numbers dropped because of, we anticipate because of COVID, they have capacity to serve far more than they did. And it is our hope that in broadening the eligibility, that those staff will be able to serve many more without a change to the budget.
So basically, you're saying there was a lot of capacity still in the system because the staff basically didn't change it, even as the number of clients served was down. So you believe we have sufficient, ability
Yes,
at this
we do.
stage?
We are very, yeah. Yes.
So there's no variation expected in the budget at this point based on increased utilization?
Not at this time, no.
Okay. All right. Thank you so much. If I could, let's ask each individual. Dr. Pagan, any questions at all?
No questions. Thank you.
Mitch, any comments or questions?
No, I think this is clearly a very important service, and I'm glad to see.
Super. Thank you, Sally.
Well, actually, I think this is a fascinating prototype for an issue that we've been discussing, and that's the provision of comprehensive services to the homeless population, to the mentally ill population, and looking at the cost per client. Although the breadth of services is wide, so you can't say it would cost whatever it is, $20,000 per patient to provide a comprehensive scope of services. It still is interesting as we start to think about it, as the mayor has discussed often, trying to get to this kind of hard to reach population and providing comprehensive services. It would be interesting to see a breakdown of the services provided by client, to see how much of them are services for a continuum of care versus a service just to provide medical, prescription medicines. Um, the range of services in terms of the intensity of work required is very diverse. So providing housing assistance would be a very time intensive service, I think. So I think, Nick, it would be worthwhile to take a deep dive into this contract to see what we've really learned about how we manage this client population. That's just a suggestion.
Yeah, no, for sure, Sally. I think that's a great comment. And I think getting more and more identification of outcomes.
Yeah.
How is this program changing things? And as Sally mentioned, not just necessarily in being able to get prescriptions and so on, but again, other issues, housing and so on. How is it making a difference? Because obviously it's a great program. I'm very excited about it. And obviously it's something that is required legally as well. But it'd be really helpful to see, are there other ways we can maybe embellish some of these if we're not getting the outcomes we expected. So anyway, hopefully, go ahead, I'm sorry.
I'm sorry, Vince, I would also be interested in the recidivism rate. I wonder how much these services are helping people land and not get back into the system.
Yep. Yeah, I think those would be
Yeah, so-
important things to sort of help bring back to us. How many people refuse? What's the recidivism? And again, some outcomes. Go ahead,
Yeah.
I'm sorry. Interrupted. Yeah, go ahead.
That was it.
Yeah, we're happy. Thank you. Happy to report back later.
Okay, super. And Barbara Lowe, any comments or questions?
Yes, this is wonderful. As some of you know, I've in the past had some involvement with the prison system in New York City. It was tremendous. I was much younger, of course, and it was tremendous because the traumas that the women experience at the time, the women I met, older and younger, and particularly the younger women were more violent, seemingly, as reported by the older women. Given all their traumas, the intensity of the interventions, I'm just concerned in holding them while they go through their ups and downs, perhaps after release. I don't know if you could just give us a bird's eye view of the kind of interventions you may be providing. And thank you so much.
Sure, thank you. Yeah, I think that's a really important thing to highlight here. Our patients are coming out of an incredibly difficult environment, and they are experiencing tremendous instability as they transition from a carceral setting back to the community. It's one of the reasons and one of the challenges of the program, actually, that there aren't requirements placed on patients. We recognize they're coming from a place where their autonomy has been significantly limited. They haven't been able to make choices for themselves. And so we try, and the case managers as part of this program are very careful not to require or steer patients. There's a desire to help patients achieve the goals that patients are directing for themselves. We hope that includes access to healthcare and some of the other things that we recognize as being particularly important, but truly it's a patient-driven service. I think in terms of the scope of intervention, I'm not a clinician, so I don't want to speak to that, but it is a contract that includes a number of psychologists and psychiatrists on staff in order to help support case managers and clients in the event that they're in the middle of crisis. And all case managers and staff go through trauma-informed care training and are very sensitive to the realities our patients experience, including for case management clients. They actually meet and start meeting with clients prior to their release from jail. So they've actually met with clients and really understand and see the environment in which they are transitioning out of and how best to support them as they return home.
And how do you get the families, particularly their children, re-engaged?
So I think that's really a client by client situation. Unfortunately, some of our clients do have ACS cases or other kind of restrictions around their engagement with children, or things that they need to be doing. So, but where there are family members who want to be part of our patients' transition back into the community, the case managers, with client permission, do reach out and engage those family members so that there's a holistic plan. So often that might include, for example, a patient returning to live with a family member and case managers helping, for example, that family apply for benefits. So it's not, again, there's not a specific intervention targeted at families. It's really a participant by participant plan, depending on the unique circumstances of that family or that client.
Thank you.
Any other questions?
I just had a quick question about
Sure,
the
Sally.
term of the settlement. It says the settlement agreement was reached in 2000. Has the service been provided since 2000, or did it just get up and running in 2018? And how long is the settlement in effect? How long will we be running the program?
So the services have been provided since 2000. Originally, they were provided under a couple of different contracts, which were known as Link and Span. Based on lessons learned, which predate me, but I can speak to some of those. There was a decision in 2017 to consolidate those contracts and to reorganize the service provision into what is now the Cran contract. So the Cran services, as described, have been provided since 2017.
I see.
And we are legally required to provide those until we're told otherwise.
So,
Until
yeah,
death
this-
do us part, I think.
Yeah,
Very-
I think so. It's Patsy. So what Ellie was talking about before, since we came over to Health and Hospitals, since CHS came over to Health and Hospitals, one of the improvements that we saw was to combine what had been separate contracts. So it was sort of one stop, not one stop, but one entry point for accessing services.
Right.
And definitely what we're trying to do here in terms of expanding the eligibility of the population and the scope of services extends beyond the Brad H settlement, which is referenced here. The court ordered stipulation still is in effect, unfortunately, after all these years, even though we continuously argue that we have substantially complied with the stipulation itself. But the services that we're offering in terms of reentry support, we would hope, I think as a service, certainly we do, would expect to extend it beyond any court mandate we already have in terms of scope and eligibility. So regardless of that court settlement and when that gets settled, we would expect to continue to support the successful reentry of our patients into the community.
And this is a city-funded contract, Patsy?
Yes.
Okay, thank you.
Yeah.
Thanks, Sally. Any other questions at all? All right, there being none, let's go to a vote then. Dr. Pagan,
Yes.
Dr. Katz,
Yes.
Sally,
Yes.
Barbara Lowe,
Yes.
and I vote yes as well. So motion does
Thank you.
have unanimous approval. And we can now go on actually to our reports, beginning with Dr. Allen and the CMO report.
Good morning, Dr. Calamia and members of the board. I'd like to share with you this morning some work that we have been doing in our clinical service lines. If we go to the next slide, we have a number of clinical service lines which are charged with implementing system-wide initiatives. For example, in critical care, we have a system-wide initiative for the artificial intelligence support of diagnosing status epilepticus. We actually have a system-wide initiative for tele-ICU consults. Under internal medicine, they're implementing high-value care, specifically looking at decreasing the utilization of unnecessary tests. Peri-op, we've been working for a couple of years under the leadership of Dr. Manish Parikh to improve our OR operational efficiency and hence increase revenue. If you go to the next slide, which shows the 5 major strategic pillars, critical care, their Cerebella initiative and their tele-ICU would fall under quality and outcomes. high-value care implementation would be care experience, peri-op would be increasing financial stability, et cetera. What we'd like to do is share with you this morning work we're doing with the maternal home and the 3-2-1 impact. I'd like to introduce the team that will be joining us at the table. If you go to the next slide, Wendy Wilcox is, actually go back a slide. Wendy Wilcox is here, who will be presenting the maternal home. Jennifer Havens from Child and Adolescent Psychiatry, and Mary McCord, pediatric primary care. This is an interdisciplinary system-wide initiative. Wendy, can you start?
Yes, good morning, and thank you so much, Dr. Allen. I'm going to be talking about the maternal mortality and morbidity reduction program update, which includes the maternal medical home. And my colleagues, Dr. Haven and Dr. McCord, will talk about 3-2-1 impact. Next slide, please. So in 2018, we started our program, and New York City Health and Hospitals was asked to devise a multi-point program to reduce maternal morbidity and mortality in New York City. At that time, about 3,000 women experienced a life-threatening event during childhood. About 30 women died each year, and Black non-Hispanic women were 8 times more likely for maternal morbidity. Black women were 3 times more likely to suffer a life-threatening event. Although New York City Department of Health has not released an updated report, we do know that those numbers have decreased, which is great news. We had a 4-point program. Our simulation program built 6 mini labs in 6 of our acute care maternity hospitals, the ones especially that have trauma centers. And we offered 3 courses. The first, cardiovascular collapse and acute life-threatening blood loss. Oh, I'm going to talk about that in the next slide. But anyway, the maternal home is the second pillar of the program. And then we successfully integrated questions into our EPIC EMR to optimize interval pregnancies. And also, most of our sites have integrated a maternal mother-baby coordinated care. Next slide, please. So in terms of simulation, as I mentioned, we built those 6 mini labs. And then in terms of the courses that we developed and are offered, OB life support, more than 85% of our staff was trained in this, and those were all multidisciplinary, multi-specialty teams, and the same with obstetric hemorrhage, and I'll talk more about hemorrhage in a second. Severe hypertension in pregnancy, we've developed the course, and the training has started, and we added one, which is counteracting unconscious bias in substance use disorder, and that course was also developed, and a pilot has started at Bellevue. Next slide, please. So we have some exciting news about obstetric simulation. We had such a great course that we developed that it was recognized by a proprietary company. They're called Health Scholars. And so they actually partnered with us to create a virtual simulation course, which is soon to be released, and we will also offer to our providers. And really the goal of this is because while in-person simulation is certainly a wonderful exercise and a great undertaking and really does set the stage for more work to be done, it's expensive, and it really is a huge lift in terms of all the providers that we have across our sites to get everyone trained. So the goal is to continue the training on the knowledge base as well as through our Relias system so that our providers will retain the information. And this work was also nationally recognized, and I will be presenting it at the 2022 National ACOG Conference, which is coming up in May. The maternal home, if you recall, was the second pillar on that. And the whole purpose of the maternal home is to provide support and comprehensive wraparound services for our pregnant persons who have need of this support. And this can either be due to clinical, behavioral health, or other factors related to social determinants of health, Right now, we employ 9 licensed social workers, with one in the pipeline, another one to be hired. And we have 6 maternal care coordinators and 3 directors for this program. This was an important program to help our patients, which we discovered through the COVID-19 pandemic. Our initial goal was to reach 2,000 high-risk women over 5 years. And as you'll see in the next slide, we've exceeded that goal. We have it implemented in, it's okay, you can go to the next one, 10 out of our 11 maternity hospitals. It was active in all 11. We had someone leave, so we're also recruiting for that position. We reached 16.4% total of the total H&H births, which was amazing. And Brooklyn had the largest segment of that population, as you can see from that slide. Next slide, please. So you can see we started in 2018 with the planning. It's really toward the end of 2018. 2019 is when we really developed it, hired persons to start, cultivated our EPIC, curated, I should say, our EPIC screens, and also had our pilot program at Kings County. 2020 was our first full year in terms of, full year of the program working, and then 2021, you'll see the numbers. So last year, we served over 2,000 unique patients and made over 6,000 referrals. 1,596 referrals were made to community-based organizations in 2021. Next slide, please. So as you can see, for medical support in management, dental had the largest number of referrals. And for pregnancy and parenting, we referred about 22% to doula services. And nurse family partnership got 13% of the referrals, as well as for lactation support. And if you look at social determinants of health, 11% of the referrals went to mental health services. And of course, we increased our WIC referrals, and as well as you can see, all the other ones that we did. Next slide, please. Now we'll go to 321 Impact.
So 321 Impact is a program that the acronym stands for Integrated Model for Parents and Children Together. And the idea, which emerged about the same time as the maternal medical home was being developed, was to bring together women's health, behavioral health, and pediatrics in a real 2-generation model that really integrates those disciplines towards the goal of supporting health outcomes and social emotional outcomes in children and in families. Next slide. The program started, the very start of the program was with the New York State Department of Health, which had something called the First 1,000 Days of Medicaid initiative, an initiative that had a 10-point program for how Medicaid can support children in the earliest phases of life. And one of those 10 points was to come up with an advanced primary care model that really supports families in this, pretty much this exact same model. Dr. Havens and I were both active on that committee. I was the co-chair, and that came out in 2019. And this program is an attempt to implement that model. Robin Hood was very interested and actually came to us to say, we want health and hospitals to be a brain building organization. And so Robin Hood was the catalyst. Health and hospitals came to the table with an equal amount of money through the venture fund, and then the mayor's office through the New York City Opportunity Office was also interested. And with these funds, we were able to start a full program at 3 sites, Bellevue, Queens, and Gouverneur. And those sites began really in 2019, but COVID came and the EPIC was a challenge. So we launched with all sites staffed and with the data collection in place in October of 2020. The next slide. The program has multiple components. The key thing is that it's a 2-generation model, and the mother and child are both supported. So linking to the maternal medical home in particular, but to women's health was key. Getting where needs are identified and support is started in women's health. Prior to this program, it was usual for the child to come into peds with and the medical team that picked them up to have essentially no knowledge of what was understood about the family and what supports were in place, except to the extent that the mother would tell us. The idea of this program, and this worked especially well with what Wendy was developing in maternal medical home, was to take the analysis of needs and the support that had begun in women's health and continue as seamlessly as possible into peds. And that includes because another key point is the pregnancy visits cover 5 to 6 months of the second 2/3 of pregnancy, but the peds support is very frequent in the first 3 years of life. We have to do 15 well visits and often more visits than that across the first 3 years, and often are trusted advisors to the parents. So it's a real opportunity to get more bang for the buck, so to speak, from what you start in women's health to carrying it out in peds and referring people even back to women's health for family planning services and for mental health services, which we integrated there. The idea of the program is that it's a prevention model and that all patients who receive primary care receive services. So it's not a selected group who are identified as having high risk, because in peds, most babies don't start with an identified high risk, especially if you're not looking at the whole family in your risk assessment. But we do, from the first visit and actually from prenatally, have a risk-tiered approach where we recognize, and as we screen and do clinical assessments, as we recognize risk, we intensify the amount of service provided by social workers and community health workers and also mental health professionals who are integrated into women's health. The key of the assessment is screening, but also clinical assessment. So there's not an automatic referral for such and such a number of on a particular screen, but the primary care team is involved in assessing the results of the screen. Connecting to community services is key, and community health workers are a key part of that. All families get parent support and education using evidence-based models that have been shown to improve cognitive and social emotional outcomes in kids. And then the number one unmet need, and probably one of the most important in terms of long-term outcomes, is parental mental health and dyadic mental health between the mother and child. It's almost impossible to get people to services, partly because the services have limited availability, but also because pregnant moms and moms with young babies, a depressed mother with a young baby, they just can't get to services for the most part. So having those services integrated in and available within the women's health service, because the service often is for women's health, but a little to some extent in peds also is important. And then finally, again, this came out of the work that was done by New York State Department of Health, Medicaid, basically, with that first 1,000 days initiative. It's going to be key for this to be recognized as what value-based care is for children. And there is a statewide conversation about this, that if you look at value-based care as being only about short-term return on investment for high-risk, high-cost people, you're not going to spend any money on children because there's only a tiny number of children that fit that bill. You do need to pay more attention to that important small number of children, but really you should see everybody as part of a prevention model. And so we're well on our way to developing a value-based payment model with partners across the state. Next slide. This is a more visual depiction of the services. The seamless connection to prenatal care is key. Healthy Steps, the Video Interaction Project, and Reach Out and Read are the evidence-based support programs that are available for all children, but especially Healthy Steps intensifies services with higher risk. We spent a lot of time on the handoff between women's health and peds. We've built a lot of tools into Epic to support that, so that when you're in peds, you can see information from the mother's chart that's important to know. The integrated behavioral health services on both sides, screening, and then of course care coordination. Next slide. The initial 6 months data, Epic is a challenge when it comes to getting good data. This is numerator data, essentially number of touches that we've had with patients in the first 6 months. We've now gotten to the point where we have our denominators working so that we'll be able to show this what percentage of children engaged in well care or in prenatal care have gotten such and such a service, and what percentage are tiered, and that are the tiered people getting more services. So that's coming out in our current data. But here you can see that in the first 6 months, we reached a lot of children. We risk stratified many families. We screened huge numbers. The integrated behavioral health, that number is a little bit inflated because this is our early measurement issues. It includes all social work encounters as well as other behavioral health encounters. So not all of that was behavioral health oriented, but they were meaningful encounters with patients. The parent support, the care coordination, and then another thing that we've worked on around the integrated behavioral health, in addition to the value-based payment discussion, is improving billing. And that's a long conversation, but it's difficult to bill for integrated services for a variety of reasons. And we've been working again with a statewide coalition and making some progress. So these are early numbers, and we can do better than that, we think, if we can convince the state, and the state is very engaged in that conversation in shifting the regulations in favor of patients. Next slide. So another key thing about this program, as I've alluded to, is that it is part of a city and statewide, it's almost a movement in pediatrics. I think this is the emerging model of care for early childhood, not just in health and hospitals, but elsewhere, though we probably are farther along than most other people in terms of really having a model and making it truly two-generational. It began with that Department of Health First 1,000 Days initiative. We have active work going on with NYU and Montefiore through Robin Hood funding to expand our early intervention closed loop referral model and the early childhood community health worker model to those other systems. And we also are expanding. We have those 3 primary sites where we piloted the full program, but we've found that many components of the program are scaling up organically. So rather than trying to plop it on sites as a whole thing, we have the community health workers now in every health and hospital's primary care practice. We have the screening up and running to some extent in every primary care practice, and it's steadily expanding to the full scope of screening using a tablet-based system that we're piloting in peds. And we have very active conversations with our managed care partners, Metroplus and Health First, and also with New York State. We are cautiously optimistic that we can have a payment model defined by 2023, and hopefully by the end of 2023, operational and financially. Next slide. And these are some just specific numbers or examples of the ripple effects across health and hospitals. The early intervention pilot has been very exciting. We're working really closely with the Department of Health Division of Early Intervention. They are really interested in this and in expanding it to other systems because it's a closed loop system and allows us, because we have the community health workers on site, and because we have an Epic-based system that we can track the referrals, we're able to intervene earlier when the referrals fall through the cracks. And we have 80% so far engaging in successfully in services of our referrals. I don't know, Wendy, do you want to take this back, or do you want me to do this?
Oh, well. So together, we're moving from reactive to proactive.
Can I just stress something here?
Absolutely.
So, as a child and adolescent psychiatrist who ran the Bellevue inpatient service for the whole service for 11 years, what we do in the mental health field is we wait till kids get old and sick before we intervene. So this proactive is really important because we know who these kids are early in life, particularly in primary care. And supporting kids and families like this really does have a profound potential to reduce mental illness in kids and adolescents, and obviously support healthy functioning. It's very hard to move the system in that direction. There's a lot of financial barriers, but this has been really transformational for our system. I also want to stress, when we RFP'd this out internally to our system when we got the Robin Hood grant, and 8 sites applied. We picked the 3 that were actually the furthest along with integrating women's health and peds and behavioral health because we needed to be successful because it was Robin Hood. But there's huge interest across the system and across the state in this work. So, and the problem is, I'm sorry to cut you off, Wendy. The problem is in pediatrics, Mary can see her kids 15 times in the first year of life for a well child visit. You actually can't do a mental health bill for a mental health intervention unless there's a diagnosis. So that's a kind of stigma, non-parity situation that we are directly addressing with DOH and OMH because we know we can do things early before people are sick to get them together, and really early support for families has a much bigger impact than later. So we are very aggressively working with the state on adapting models that California and Massachusetts is using, where you can use risk coding, Z coding instead of actual psychiatric diagnosis, so you can do preventive work with families. We are working very hard at expanding the women's health model from Wendy's model, which is focused on higher risk mom, to all moms, and working very closely, Natalia, with Eva around changing the culture of social work, because it's been so hard for social workers to get reimbursed for behavioral health interventions, even though they can bill for them if they're licensed or supervised by a licensed person. We historically have not done that. And we're going through a culture change. So in addition to the many things social workers do, they can provide direct interventional supports. Our hopes is that we can also figure out how to interface things like depression prevention in women's health and keep people healthy. The problem, I remember, Michelle, when you decided to roll out depression screening across the system, and I went bananas because the problem is pediatricians aren't going to treat the mothers. OBGYNs aren't going to treat the mothers because they're gone. So how do you build a bubble around women and families so they can get the behavioral health services there? They're not going to go to the mental health clinic. The adult psychiatry people aren't going to have the capacity to deal with pregnant or just delivered women. So really building a model where we can support these families as early as possible.
So I think the last slide is self-explanatory, and we just spent a lot of time talking about the dyadic model, the two-generation model. And in the interest of time, Dr. Calamia, any questions or concerns or comments?
Just my one comment is, again, this is just such cutting edge work, huge national implications, just yeoman's work. Amazing job, amazing team that you all have organized to do this. I think it's worthy of presenting this to our whole board. I don't think the sustainability issue is in question, but I think the more the board as a whole understands the program and the value of it, even if we don't see bottom line sometimes, initially the way the models are constructed and reimbursement, because these things have huge positive impact down the road. So that's my comment. Otherwise, I'll leave it open to the other board members to have any other comments. But great presentation and great work. Thank you.
I'll just second everything that Dr. Calamia said. It would be great to have the full board hear about this because of the way you're thinking about integrating services. And many times, it's not only a challenge to integrate them, but how to pay for them. And you have been thinking about all these elements and how to look at high-risk populations, simulation, and so on. And I see it at many meetings and things like this, and I haven't seen anything like this before, where you're looking at so many parts. So I guess the only question I had was when you go to, for example, the state, and I'm just speaking the state or the foundation, and say, here's what we're doing and all of this, what is the sort of like, what is the biggest issue that they bring up or difficulty on doing this? Is it coding? Is it like inability to think about how to pay for it or change the way things work?
Of course, I would say this, but it's really, I'd call it a phobia about behavioral health billing.
So the behavioral health part of it is it.
They've made it extremely difficult. Social workers only recently have been allowed to bill, and they're licensed in the Article 31 settings. They bill all the time independently. They had it set up so it was for pregnant women only or kids under 21. And for the postpartum period, it was 60 days and you had to have a diagnosis of postpartum depression. Now we've gotten them to completely loosen that up to a year. Postpartum should actually be 3, we think. And they've broadened the range of, so we have to have the social workers in our primary care systems be able to generate revenue for the work that they do.
And it is also the coding and paying for it, because a lot of the work is delivered by people that are non-billing providers, the community health workers being the prime example. And that's a similar phobia that if you allow that, then everybody could bill for anything. And so the conversation keeps reverting to, let's just do the highest risk group. But the whole point of the model is you have to start with the prevention lens, and really, you can't siphon off a small group to get a selected service. And lots of people in the state understand and believe in the model, but when it comes down to the nitty gritty of how to structure it in a payment model, we have a lot of people on board. It's a serious
Yes, we do.
discussion, but it's a challenge to come up with a model.
We got the 2-generational primary care model into Kathy Hochul's budget.
So I
Wow.
can spend the next 2 hours talking about the payment side, but I'll stop here. Thank you so much for your presentation.
Also, in the interest of time, any other comments, Sally, Barbara,
Yes,
and
just
Mitch?
briefly,
Mhm,
just
sure.
briefly.
Yeah, Barbara.
A wonderful model. I've wanted to see mommy and children together in therapy for a long time. So bravo, it's just wonderful. I would like to hear how it goes over time and all the wonderful things you've designed to be done, whether it's integrated or I think it's wonderful. And so hopefully you will continue and the children will be inoculated, if you will, from some of the things that they we often see them get involved with without having a parent in their lives. Thank you.
I would just add, well, first, I was hoping to hear Jose's 2-hour lecture on.
Yeah, I want to hear that, Jose.
We can still work on that, Mitch.
Reimbursements. We can maybe, we could ask Colicia to schedule that at another time, because it is
careful, be
amazing
careful.
how many of
No,
the
I wanna hear it.
problems of healthcare systems stem from that.
Yep.
And, I mean, the most general statement of the issue is that health insurance, and therefore Medicaid, because Medicaid is based on paying for the same things health insurance pays for, except for lower income people, is really based on a model of diagnosis and assessment. It's based on the idea patient comes, patient gets test, patient gets diagnosis, patient leaves. Talking to people in all settings is really not a valued thing, whether you're talking to somebody about, stress reduction or, increasing their exercise or their substandard housing or their abusive spouse. Really, none of that is covered. It's not, it's a huge problem. The conceptual model has to move to all of the things that people need to have good health and the right people to do that. And you don't want to pay doctors to do that. That's not necessary. Community health workers will do better, but you have to pay them. And it's just really frustrating that everything is so stuck in this, diagnosis and assessment model. But our great physicians and other staff have clearly figured out a way to move beyond that, and I'm very grateful. So thank you to them.
I just have a quick comment and a question. About what percentage of our patients would you say have to deal with postpartum depression, Michelle?
Probably around 10%, not of all severity. That would include the least severe as well as the most severe.
Right. Because I have to say, it's having dealt with it when it wasn't recognized, it's a horribly incapacitating condition. And I'm so glad that we are handling it. My second comment is just about the Medicaid expansion recently for an additional year of Medicaid. for women
Mhm.
post-pregnancy.
Right,
I hope
right.
that will
Yep.
be helpful to this. It's mind-boggling how much you're doing. It's just mind-boggling. Thank you.
Thank you.
Thank you for the great presentation. Again, I know we really didn't leave much time. Just to let everyone know, there are full detailed reports from nursing as well as Metroplus. But I will leave you each, Dr. Sinhez first, and then Dr. Schwartz. If you could somehow capsulize that fabulous report in 3 minutes or so, I would appreciate it. But Dr. Sinhez.
Sure. Good morning. So in line with our conversation around social workers, the Office of Patient-Centered Care most recently celebrated our social workers with a champion luncheon held April 1st, where we had over 290 members of our workforce come and support our social workers. We awarded 42 social workers with champion awards. New York City Health and Hospitals has also successfully launched the New York State Staffing Committee at our 11 acute care hospitals and our LTAC. We also most recently completed a Directors of Nursing Quality training, which is really instrumental and integral to our nursing excellence journey, where we trained 15 Directors of Nursing Quality on best practices, infection prevention, technology utilization, Indian QI data submission. The guest speakers included the Office of Quality Patient Safety, MNPA, Press Ganey, Indian QI, and Haney's. We have also successfully launched the CUNY and H&H Academic Partnership. This is the first annual Health Equity Forum for Nursing, where we had over 190 members from CUNY and Health and Hospitals on March 18th, really talk about health equity research, practice, and education. Our breakout sessions included Race Matters and Healthcare Matters, The Future is You, sharing knowledge and experience. Last but not least, I would like to share that our system has launched nurse leader work groups, where we will have 12 different work groups, and nurse leaders will really revamp our orientation, create a nurse leader academy, take a look at annual competencies for nurse leaders, focus on continuing education, development, certifications. We will also create a mentorship and succession planning committee, and also take a look at diversity, inclusion, equity, and access opportunities for nurse leaders. We will also ensure that we create formal recognition programs for our leaders across the system. So we continue in a journey of nursing excellence, where we're kicking off a lot of Pathway to Excellence engagement programs across the system, and also beacon recognition for our critical care nurses across the system. So very proud of the work that we're doing within social work and nursing across the system. Thank you.
Thank you so much. And again, there's a detailed report that was submitted by Dr. Sinez. Let me move on to Dr. Schwartz then. Yet I know lots of things going on with Metroplus in a very brief time to talk about it, but if you could just summarize, that would be super. Thank you.
Sure. Good morning. It's Sanjeev Shah, Dr. Schwartz this morning. 4 very brief points. First, to alert the committee that recertification for individuals with Medicaid, Essential Plan, and Child and Adult Plus is likely to return later this year after the moratorium imposed as a result of the public health emergency. A significant undertaking to get all these individuals recertified when it is announced within a 14-month window. The other piece is to alert the committee about federal laws impacting transparency. This will have impact on those individuals who are enrolled in qualified health plans and other plans like Metroplus Gold, where cost sharing is impactful. These federal provisions require managed care plans to provide consumers with insight into how much a proposed service is going to cost them as it relates to deductibles, co-payments, and other cost-sharing initiatives. The first iteration of this has to be in place by June of this year in terms of a price comparison tool, and then by next year, actual insight into discrete services, about 500 or so shoppable services, so consumers can select the provider, but also select how much it's going to cost them in terms of out-of-pocket costs. The third item is the successful implementation as of February 1 of this year in a telehealth initiative This is a value-added service, separate and distinct from telemedicine services that are provided as part of primary care, specialty care services. This is extra contractual service provided by Metroplus Health Plan to its members, regardless of their attributed PCP. It had been under a vendor, Amwell, up till January of 2022. But as of February 1 of this year, it's been shifted to New York City Health and Hospitals Express Care. So any Metroplus member with an urgent need can contact a provider out of hours and then be transitioned eventually to either a primary care, specialty care, or other appropriate service. It has undergone a successful implementation, still refining going on in terms of answer time and abandonment rates and things of that sort, but certainly an improvement to what was in place with Amwell. We're experiencing about 200 calls a week. 20% of the calls when they do want to connect to a provider is actually related to a mental health service. And then lastly, just to announce to the committee that Metroplus was awarded a $6 million as part of the HIV Special Needs Plan New York State Department of Health Quality Incentive Award. This is related to work that was done for measurement year 2019. You can see the delays that are in place in terms of awarding this incentive award. But suffice it to say that this was based upon quality measures like viral load suppression, consumer satisfaction, and other compliance measures, as well as a whole gamut of measures unrelated to HIV care, but important in terms of the comprehensive care that these individuals deserve, such as breast cancer screening, cervical cancer screening, colorectal cancer screening, initiation of appropriate control of medications for those who have HIV and asthma, for example, or HIV and diabetes in terms of A1C control. So Metroplus earned $6.5 million as a result of that work, and that was received by the plan in February of this year. Thank you.
Super, congratulations. We're already a few minutes over, so if there's any comments though, or questions that any board members had, you can ask now. Otherwise, if there's no new business, no old business, I consider the meeting adjourned. I thank you for your time.
Thank you.
Thank you.
Thank you.